It's the long-term care insurance component of the act, and it passed. It does provide, it's supposed to be completely self-funded, and what it does is sort of switch things around to require employers to offer long-term care insurance to all employees, and then employees can opt out. So basically everybody gets it unless they say they don't want it. They have to pay for it. And so it's not really funded at the federal level, but it is a way to significantly expand long-term care insurance. And that is another important part for the state to be aware of, because there is hope that, you know, the huge percentage of the Medicaid budget goes for long-term care. In fact, I think 47% of the Medicaid budget goes for those who are dual eligible, even though they represent only 17% of the Medicaid population. And so if some of those got private long-term care insurance, the feeling is that they would be significantly, again, save significant dollars for the state. It's in the law. The regulations have not come out yet, but you do have to be employed to get it. So it's a little bit limited, but it's better than what we have today. Yeah.
You said there's a lot of decisions and activities that the state will have to take. Are those things for the legislature to deal with, or the executive?
Well, that's a very good question, and there's a mix. I mean, there are some things that the legislature, and our legislative staffers are smiling because they're involved. There are some things the legislature does need to pass to implement, and there's discussion going on, I think, right now in the legislature about some of those things. There are, many of these things will be at the department level. And so right now the department has set up, the governor has set up a task force that spans multiple departments, includes the insurance commissioner and Janet, I think, chair it, right? They're involved in looking at implementing the things that are most important that have to be implemented in 2010. And they're doing some cataloging of what has to happen at the state level over time. But again, there'll be a whole different group of people at the leadership level that will actually be involved after January. So, and most of these things, I would say, a lot of even the demonstration projects, the grants, most of the pieces in the law specify the state has to apply. Even if private entities, nonprofit entities, providers want to participate, the state has to be the applicant to get those. So it's very important at the state administrative level. Yes?
Yeah, you mentioned outreach as being key.
Yes.
As far as the newly eligible Medicaid. Are you going to be doing any research in this area, or have you done it already, so that we can pick up on some of these examples?
A good question. I'm glad that you asked that. Actually, we just talked about that this morning. There is an access coalition in the state, MIAC, and they're very interested on how we can implement health reform. And we did offer on their behalf to take a look at what other states have done. We know, for example, in Wisconsin, they've done automatic enrollment. I don't know how much you know about how well that's worked, or others from Medicaid here know that, but they had some interesting, I just saw some data from them. They had some very interesting data about how they, how they got people enrolled. It's a very complex issue. It's a very complex issue for our state because of our, workforce issues, systems issues, a lot of technical issues, but we are going to be looking at what other states have done to see whether there are some models that could be implemented here in Michigan. So, great question. Others? Yes, Rick.
Now, excuse me, I hasten to point out now I understand this whole thing, thank you. In the context of the budget situation we have in Michigan, would you say something, please, about the maintenance, this maintenance of effort requirement?
Yeah, of course, that is a requirement in the law right now, maintenance of effort, which means no state can cut the eligibility for Medicaid starting now, or starting with after the law passed. Which is the challenge. And you could say more about what's happening. Why don't you say a bit about what's happening in Congress on the FMAP? Because I don't know how many of you are, and Eileen could talk about this too, because as a result of the stimulus bill, we got extra funding, all states got extra funding for a federal match. So we're getting more money at the federal level than we have historically for Medicaid. Because of the politics in Washington, there's been a discussion about extending that. It's expiring. There's a discussion about extending that higher match rate, and the deficit hawks in Washington are winning the debate right now, and they're not approving that extension, which I believe is a $500 million issue for Michigan, something like that.
Between $500 to $600 million.
between 5 and 600 million money we will lose as a state if that in fiscal 11 if that FMAP extension does not occur, and we have limited, because of Rick's Rick's making a good point, we have limited choices on what to do to make up for that money in the Medicaid budget, because we cannot cut eligibility because the bill requires maintenance of effort by the states. And so there have been, as I've heard, some pretty dramatic proposals if we have to cut 500 to 600 million of cutting provider payments 35%. And if you go back and look at our survey, you'll know that even with slightly better Medicaid payments, people were having a hard time, particularly we think, finding specialists who would take care of them. So if you think it's hard to get access to health care and Medicaid now, if you cut provider payments 35%, we may have coverage, but we may have absolutely no access to health care. And that goes back to the title of, that will hurt the health of our population. So it's a huge issue. Yeah, go ahead.
Comment about people eligible for Medicaid who are not enrolled.
Yeah.
The data on income from, say, the census long form or the American Community Survey or the current population survey, it's based on people who are considered members of the household. So, for example, if you have a household where someone is the spouse of someone serving in the military, that person serving in the military, whether they're living in North Carolina or Iraq or stationed somewhere else, they're not part of the household as far as the census is concerned. Mm-hmm. And that means that their income is not part of the household income. Mm-hmm. So a certain number of single moms with children, or moms with no husband present with children, who appear to be living in poverty, actually have a spouse who's serving in the military or working in Iowa because they can't find a job here, and it might look from the statistics that they're eligible for Medicaid based on income, but in fact, if they were to apply, it would be found that, well, actually, you're being supported by a spouse elsewhere.
Our expert on, go ahead. Eileen, say who you are for a minute, just for those who don't know you.
Alice from Health Management Associates. And the data that the Kaiser Family Foundation has published on their website was done by the Urban Institute, and they actually, it's CPS, which is unfortunate because it's not as large of a survey as the American Community Survey, but they went underneath the household level and disaggregated the households. And so
that's the data we're reporting.
They did health insurance units rather than households. So I'm much more confident of their information because, Ken, I'll give you a flip of your example, which is my sister-in-law, who is disabled, is currently living in my home and would count on a household survey as if she was part of my family. Yeah, Social Security, disabilities are up there. And so that would be a counter to that. So I'm really comfortable with the Urban Institute's micro-simulation and their modeling that disaggregated health insurance unit rather than households.
And that's the data we use to report here. So,
but Ken is absolutely right. If you use household income, it's a mismatch to what is a health insurance unit.
Yeah, so how would they bring the income of the...
Yes, you guys can sidebar. We'd always love to help purify our data, so if you we'd love to anything you conclude from that. That's great. Thank you. Yes?
What are the state's options in expanding Medicaid?
Yeah, so one of the things I didn't say is the state does have an option to expand Medicaid now. They don't get the higher match. It's called an early adopter option. And one state, Connecticut, one of the eastern states, I thought one, but maybe small states have just implemented the Medicaid expansion up to the 133% of poverty. If you start, you can phase it in. You have to start with the lowest income segment of the population. So I know the state was looking at those adult benefit waiver clients who currently get Medicaid coverage and who will no longer get that coverage after January as being a possible early adopter phase-in. Given our state's budget crisis, given the FMAP issue, obviously we have huge issues on finding the match. But the state does have the option to phase it in. After 2014, those options, everybody has to have everyone in up to 133% of poverty. So the options go away. It's just